Okay, everybody, let's take our seats. A 1 minute warning, please. 1 minute. Takes a while, that minute, doesn't it? Okay, so I've got exactly 2 o'clock on my clock now, so we're gonna kick off. Ready to go. So just a reminder to everybody that we are live streaming to the public, and welcome to you all to the Suffolk and North East Essex Integrated Care Board meeting for May, 23rd of May. So lovely to see you all. First of all, notification of any questions from members of the public. So Joe, do we have any questions in prior? So in which case then the questions, if there are any at the end, and Simon, I'll come to you for any that might come through the live stream. Okay, thank you very much. So apologies. Now I've got a list here, but again, Joe, correct me if I get this wrong. So we have apologies from Frida Batty, from Ewan Cameron, but Craig, you're deputising. Thank you very much for that. From Sue Cook and Stuart, you're deputising for Stuart. Thank you. Richard Watson, Steve Feast, Andrew Reed, Patrick Warren Higgs, Peter Whiteman, and Edward Creasy. So is that complete, Joe? Okay, that's good. And then something for us to note, I think, and an opportunity for us to say thanks and appreciation for the work so far. This is actually the last meeting for Steve Clark and Patrick Warren Higgs, both of whom are going on to bigger and better things. So, Steve, obviously we're recording Patrick's moving on, and our appreciation and our thanks to him. But Steve, we've got an appropriate opportunity here to say thank you to you for everything you've done in the last 10 months. It seems a lot longer in so many ways. But do you want to say a few words at all?
Not particularly, no.
No.
It's a requirement that I step down on the basis that I'm involved with the dental CIC in the local area. As a consequence, I can't do the two things. So
yeah.
Only one.
Them's the rules.
Them's the rules.
Yeah.
So I have to step down. So yeah. Thank you for your kind words, and I wish you all well.
Thank you very much.
I'll probably be back with as part of the CIC.
Yeah,
something else later.
We'll see you again, no doubt. So thanks for that. Declarations of interest, item 3. Are there any declarations of interest or potential conflict of interest with any agenda item other than those of which we're aware of course? None noted. Thanks very much. So minutes of the previous meeting, which was the 21st of March. There are 15 pages, but shall we see if we can do them en bloc? Are there any issues? Let's zoom for accuracy first. Are there any issues on accuracy with respect to those minutes, or is everybody content that they are a true and accurate record? No objections, no disagreements. So shall we resolve that the board agreed the draft minutes as presented as a true and accurate record of the meeting of the 21st of March? Everybody happy? Good, thank you very much. In which case, let's then move on to item 5, which is the matters arising paper. So let me just get to that on my screen. And we have 5 open matters arising in the action log and 2 complete. Let's just deal with the 2 complete first. Is everybody content that they are complete and you're happy with the update given? Good. In which case, then let's just whiz through the 5 that are open. And the first one is 22060, which is digital care technology services. Any further update, Andrew?
Yes, so that action is dealt with under agenda item 10, so I suggest it's now closed.
On the agenda, so we'll close it if everybody's content. Thank you. Then 23022, policy endorsement, Amanda.
Thank you, Chair. So this action remains open and we continue to have real conversations or live conversations with the HRD community with the view that ultimately we will get to a position of sharing policies moving forward. But at the moment, that's been delegated from us to the People Committee that we're working through.
Okay, thanks, Amanda. Everybody happy with that one? Good. In which case, 23035, the physical activity pathways, etc. Shall I come back to you, Amanda?
Yes, thank you, Chair. So that's on the agenda for the Estates Committee, who are meeting on the 30th of May. Following that presentation, as we recorded at the last board meeting, that item will come back to a future board development in terms of the wider estate configuration.
So we'll schedule that onto a future meeting. Good. In which case, 23037, there's 3 sub-points here. The first one, Amanda, is down to you, but it's noted as complete. Do you want to comment on that at all?
I don't think there is anything further to comment. It has been completed through the Urgent Emergency Care Committee, ably supported by Paul. Did you want to add anything, Paul?
No.
Okay, thank you.
Thanks, Amanda. Any question for Amanda on that one? Otherwise, Paul, numbers 2 and 3 are both down to you. Any updates?
Yes, if I may, Chair. Just very quickly, the 2 things on the back of the last board. One, I sought assurances from the team that the Living Well Health Watch work had been taken into consideration into the future programmes, and that is coming to the elective committee on Thursday for discussion and review. I'm aware, though, from a Health Watch point of view, that we probably haven't communicated as well in terms of what we've done. So the purpose of that meeting is to discuss that thoroughly and make sure we pick up those issues at that meeting.
Okay, thank you. Any questions for Paul? Otherwise, happy. And then 23. Oh, sorry, Paul.
Yeah, done.
You come. Is that you done, or are you?
No, I was going to do the second point.
Do the second one, number 3. Yeah.
Yeah. Just to say that's part of the performance report update, so I'll pick it up as part of the agenda if that's okay. Thank you.
That's fine. Yeah. Any questions? Everybody happy? Good. In which case, 23038, the governance update on pod, etc. Maddie, shall I come to you for that one? Are you happy to give an update, or do you want Ed to? Are you happy to go to Ed? Okay, all yours, Ed.
So this was a question around representation at this board in terms of pharmacy, dental and optometry. So we have a primary care committee where those professions will be represented for now. We'll consider in the future whether we want to change the constitution of this board, but for now I think that's probably the right way forward, and we'll have a good feed through from that committee via the Alliance Directors and our Medical Director.
So work in progress. Will the board get a future update, Ed? And should we leave that on as an action to update the board in due course?
If the board would like.
Yeah, board members happy with that, or do you want it closed? Are you happy with the action?
Process? Close it.
Close it? Oh, that's good. Like a closed action. Everybody happy? Good. In which case, complete. Thank you very much. So any questions in general on those updates? Everybody content? And then on the matters arising and the action log itself, are you content that that also represented a true and accurate record of the actions that were captured were the right ones, and there were no actions which should have been captured that were missed off from the 21st of March? So complete. Everybody content? Great, thanks very much. So action log matters arising endorsed. In which case, then moving on to the general update. Ed, over to you.
Thank you. I've had to cut down this update, so I think I could have been here a long time, so I'll be very succinct. So firstly, just a big thank you to all colleagues who supported the recent industrial action that we had since we last met. I think it'd be fair to say that the challenges and the risks during the recent nurses' strike was significant. We had particular challenges at Colchester Hospital, which was managed exceptionally well by the team, the same way we saw at Ipswich and at West Suffolk. But it was a very, very challenging period. The BMA have announced further junior doctor strikes, I think from the 14th to the 17th of June. I know Nick's been interviewed recently today by the media on that. So again, another very high profile strike to cope with, but thank you for everyone's ongoing efforts to support staff and to keep services safe. Secondly, a big congratulations to the stroke team at West Suffolk Foundation Trust. The recent Sentinel Stroke National Audit Programme has rated West Suffolk as giving the highest quality care for stroke in the UK in the last quarter, and the team have achieved an A rating every quarter for the last 5 years. So that's an incredible achievement. So I just wanted to put on record how grateful we are to the team and for the care they're providing to their patients. Thirdly, I'm really pleased that we have launched a community hub within the system, which is just physically based at Constantine House over the road. This brings together our community teams, our ambulance service teams, our 111 provider and others to proactively pull patients from the ambulance stack to ensure that where possible we can support people in the community rather than necessarily conveying them into the emergency departments. This is a leading edge piece of work in the East of England. All of the other East of England ICBs are going to follow. So collectively we'll have a very strong, I think, service offer, and I think it reflects the excellent partnership working that we're now enjoying with the Ambulance Trust. And in particular, I want to say thank you to Neil Maloney, who has spearheaded this work very effectively. And Neil's taken a secondment in the National Urgent Care Team, so we wish him well too with that work. The next quick update was that we have started a programme of reverse jobs fairs. We've held one in Colchester and recently one in Ipswich, with plans also for the west of Suffolk as well. And this is an inclusive approach to employment, particularly supporting people with learning disability and autism, where the employers visit at the fair the candidates rather than the other way around, and work on building on people's assets and opportunities and proactively look at opportunities for employment. And it's been a really successful, innovative approach that has come out of the Essex Anchors network and now being spread into Suffolk. And we think it's a really strong way of working that we can apply in all sorts of different contexts in the future. The next one is that we've had 2 visits from Amanda Pritchard, the Chief Executive of NHS England. Amanda was hosted by Nick and colleagues at Ipswich Hospital recently to showcase a lot of the work at ESNEF, but also to open the new breast care centre, which is a fantastic asset in our system. And secondly, she met with us around our planning. The key things we went through was the financial position for the system, waiting list recovery, outpatient reforms, particularly looking at how we can accelerate transformation plans there, and ambulance performance. So those are the main areas that we discussed, and she gave a very positive appraisal at the end of how the system was working. So that was great. Final 3 things is our ICP is organising through Susanna an expo event on the 7th of July, which you're all very welcome to attend. I can't believe it's a year since the one in Newmarket, and the theme for the day is around time to value every voice in health and care. So there's a particular equality and diversity and inclusion theme that we're organising for that event, which is at Worsted Park in Ipswich. This morning I was chairing a conference on our CareTech campus, which I'm sponsoring at the University of Essex. So we're looking to establish the first CareTech campus in the country. And we had a brilliant attendance from both health and social care and industry, who are very keen to progress this. So if it does continue to build momentum, perhaps we could organise a presentation here so the board can engage with it. But the idea is to test new CareTech innovation within SNE and neighbouring systems, so that we can build on the progress we've already had with Cassius and similar, but to go even further. So it's very, very exciting piece of work to be involved with. Then finally, I'm sure we will have spotted that there's been significant local elections recently in our councils. There are new cabinets forming. Many are coalition governments, as it were, and we'll look forward to working with those new teams once they're established. Thank you, Will.
Ed, thank you very much for that update. And any questions for Ed? Any additional points that you'd like to make or raise? Otherwise, shall we say received and noted? And thank you for all that positive news. And also thanks from the board members to the teams involved in bringing those matters to the point, to fruition, to the points that they've reached thus far. Okay, everybody content? In which case, let's move on. Item 7, the IES Alliance update. But Maddie, I'm going to hand over to you and Tom. So
thank you very
all
much.
yours.
Yes, thank you. I'm not sure that Tom actually needs any introduction, but I'm delighted that you're here. Thank you for coming to tell us further about the partnership with the Alliance. So the Green Light Trust's delivery really exemplifies everything which we're seeking to achieve as an alliance. The delivery of a highly personalised and holistic approach to meeting the needs of individuals with complex and high-intensity care needs. Maximising the potential of our beautiful county, our green assets, a direct partnership with our statutory providers in general practice and in NSFT, and crucially as well, robust monitoring, evaluation and sharing of learning, which is really important to us in the next stages of our journey. So with that, I'll hand straight over to Tom. Thank you.
Thanks. Okay, there we go. Thanks, that's a lot to live up to. There's kind of 3 points that I want to try and leave you with. The first one being that what I'm going to introduce and present to you is a kind of proven model that I believe has the potential to unlock the third sector, the third sector's potential. Again, as Maddie said, that there's kind of robust impact measurement and demonstration throughout what we do, and in addition to that whilst predominantly we work with high intensity users of services, that actually there is the potential for that work to have system-wide and whole population impact. But I'll talk about that as we go through. Wow, that worked. That's surprising. So Greenlight Trust as an organisation is described as an environmental education charity, which is a really rubbish way of describing what we do. Fundamentally, we work with the most marginalised and disadvantaged in society, and we use the natural environment as a medium to engage them. We do that through multiple sites, and I'll talk about that as I go through this presentation. I've got a relatively short amount of time and quite a lot to say, so I will rattle through relatively quickly. Our approach is to integrate alongside other services rather than to be an either-or offer. And the idea, what that sees is us work in partnership with NSFT, with other statutory services across social care and the education system. And the intention of what we're trying to do is trying to remodel the high-intensity users' use of services into something that meets their needs, not replace what is already there, really. So we describe our vision as a society where everyone has equitable access to the power of nature. And by access, what we don't mean is just geographical proximity to the natural environment. What we mean is the vast majority of the people that we work with, the natural environment just isn't a part of their lives. And we know, as it says here, there are significant health determinants that are influenced by engaging with the natural environment, things like dietary choices, cortisol levels, birth weights, exercise, and a whole load of others that we could go into. But we also know that those who face the greatest inequalities in society also have the greatest inequality of access to the natural environment. When I press the button, a video should show, and I'm hoping it works and the sound comes out. And I'm going to talk about the video afterwards, so I'll explain. It's pretty self-explanatory.
We were originally a first response service, and we launched in April of 2020 because there was a national requirement that every area has a mental health option, emergency line to call into, and that was a response from the pandemic. We switched in April of this year to 111 mental health option, so that's what it's called now. People that call very, very regularly, not necessarily appropriately to the service. Those are all individuals that sort of would call in and not necessarily are in mental health crisis at that time, triageable mental health crisis by our definition. We were managing them, but we didn't really have anywhere to direct them. And that's sort of where it then led to sort of this point where Greenlight Trust has been supporting those individuals. What it's done is it's provided that additional support, almost emotional support, social contact that people were lacking throughout COVID, that led to them needing to call us multiple times a day to sort of have that contact with individuals. A lot of the people that we have referred over are very isolated. Some of them do have very chronic mental health conditions as well that have been very long-standing for a number of years. And it's sort of that their community team is managing them on the day-to-day basis, but the social aspect is really left out, and we know how important that is in recovery anyway. So the pilot, obviously, with Greenlight Trust filled in that gap of that outside support that needed to sort of encase these people that we couldn't provide as a service, because we were just there 24/7. So people would automatically just pick up the phone and dial us. I know first response is going to pick up. I know that they're going to support me. It did get to a point where we were sort of at that point, okay, well, are you safe at the moment? And if they were saying yes, we were saying, you know, the options that you have now, we're not the appropriate thing. The only thing that we can direct you to right now is Samaritans. And that's that.
We had a woman referred who was really unwell mentally and was calling the FRS line a lot. She was their highest user, but she was using it because she was lonely, and she needed to be reintegrated back into the community. She lives on her own. She's an elderly lady, so she was referred to us, and we worked with her for 3 months just to build that relationship before she would even consider coming and meeting face to face. We got her into the woods for a walk. She brought a care coordinator, which was fine, because she was a constant in her life at that time. And we had a walk around the woods, and she fell in love, as do most people. And then as we got to know her more, we recognised that she was struggling at home, and there were still days when she was feeling quite low and lonely. So we referred her to WILO, which is Your Life, Our Help. And they are now visiting twice a week. So she has that extra social support. They help with her shopping, her home life. And she's re-engaged now in 2 GLT courses, and she loves it. It's about understanding that individual and where they need to be. When they refer to us, each participant gets an allocated budget from the whole budget, and we can use that for referring to other places and for using the GLT courses. So that all comes out of that budget as well. And we can use the budget for transport as well. So if they are isolated in areas that there's not great public transport, or they're not capable to use public transport, we can use that budget to get them to places that they might not otherwise be able to get to. We have a designated PEC just to work with these individuals. These were people that were isolated and lonely and had no other option but to keep calling that line. we are not a replacement for that service, and that forms part of the initial contact with the individual. You know, we are not mental health specialists, we are not trained counsellors, trained therapists, so we're not a replacement. So they can continue to use that service with the FRS, but what we hope to see and what we are seeing is that reduction, and on some cases it's stopping. This was a pilot. It has worked. There are areas where we've recognised that actually we might adapt that, but it's worked. We've seen the figures, met the people, and it's working. And if it works in Suffolk, it can work anywhere.
So that's an example of one pathway. That was a pilot that has been operated over the last 12 months. That's now been extended, and it went through procurement, and we secured it on a 3+2 year contract, and we're developing that further. I'll talk a little bit about the additional outcomes that we're seeing. So Greenlight Trust as a charity covers it. We started in Suffolk, we've now moved into Norfolk, and actually that piece of work has already been commissioned by Norfolk and Waveney ICB as well, and that is now getting up and running. So at the moment in Suffolk we operate from 6 sites, and we have 3 new sites that are planned. As a model, we deliver from our sites, and we're just building a new building on the outskirts of Ipswich next to that site. But on the vast majority of them are with our partners, so National Trust, RSPB, and we're just talking to the Wildlife Trust in Suffolk and Norfolk about additional sites. These are the people that we engage with: adults, children, and young people. We have a sister project to the one that you've just seen the video on, which has been commissioned on the same basis, where we're working with children and young people across the CAMS service, and they're taking direct referrals into a very similar offering, where effectively our participant engagement coordinators are engaging with them and getting them onto our programs and funding them onto other organisations' programs. The direct impact that we see, we measure things like reduction in GP visits, A&E visits, police interactions, and changes in wellbeing through several different wellbeing scales relative to the individuals that we're working with. And our approach is all about building a relationship. So fundamentally what we're trying to do, and Jane, who you saw in the video, manages all of our participant engagement coordinators, and they fundamentally, because the people that we work with are disengaged, that's what they need. And for some of them, that will take up to 3 months of an investment of time to build a relationship with that individual. We have young people where that relationship starts as a pen pal relationship before they will meet an individual to gain that trust. And we're able, through the work that we do, we're able to invest that time. What we're doing it's not about signposting, and what we're trying to do is very subtly address the barriers that are creating that kind of high intensity use of services, which is kind of misdirected use. So, and as it says there, we are working alongside those partners. And I think, excuse me, that's been one of the real successes of this as a model, is that it's working in partnership. So with our colleagues in the NSFT in particular. We have 4 stages to what we do. The rebuild stage is where we're working with people with kind of severe and enduring mental illness. They may be in crisis at that point. And there's a real intense engagement from the participant engagement coordinators at that point to try and understand what it is that we need to put in place to support them. The vast majority, so that's high intensity but quite low numbers. The vast majority of participants come in at this support phase, where that's much broader, where they get, it's the same interventions, but the participant engagement coordinator support is slightly lower. The idea that we're trying to do is progress them into what we call an enablement phase, where people have less support from us, but we're able to help them adhere to their recovery. And then beyond that, in this final stage, which is Empower, is where they will move into maybe education, employment. And at the moment, we've got about 80 staff, and about 15% of our staff complement is made up of people who've been on that whole journey, trained, and then come back to work for us. Data is a really important part of what we do. Another really beneficial thing about the way that we've been working in partnership is we've been using health system data to demonstrate the impact of our work. So this is data that indicates someone who's on that or it's 111 mental health option program now. The green square is the point that we began to engage with them. And that's the period that is mapped out along the bottom of there. So obviously it's anonymized. And the idea is that what this is showing is NSFT actually tracked that data. It's showing a significant reduction in the use of that service, but also wider services as well. The examples of impact, I've put two up here. So if we talk about that 111 mental health option work that we've been doing, we now have a year-long data set for the first 25 people who came into that service. We've shown that it's 76% effective at reducing their use of that service, but on average across that cohort, there's a 55% reduction in their use of that one service alone. But in addition to that, there's a 60% reduction in community mental health services and psychological services. There's a significant impact on the individuals who we're supporting through that. What we also expect to see is a significant impact in other areas. So I met with Georgia Chimbani from Suffolk County Council to talk about measuring and demonstrating those impacts that we see across social care as well. Another example that's up there is part of a pilot that we've done within primary care. So we have work that we're doing across primary care as well, again working with the highest intensity users, and it tends to be mental health that we're seeing people fall within that. And what we've demonstrated in there is a 32% reduction in direct interactions with the GP surgery, and quite significant outcomes, because we don't have such with the 111 service. Really easy, nice KPI that we could look as there's that one thing, we reduce their use of that phone line, whereas across primary care there's a much broader set of symptoms and things that we're trying to address. How much time have I got?
You're okay. Keep going.
Oh, okay. Keep going. Okay. So I left a couple of slides on the end, depending on how much time I had. So one of the things that I've been talking, and I've met with Andrew and other people to talk about this, is about how we are looking at how the work that we're doing and the reduction of redirection of high intensity use actually has a greater impact on the whole population. And the theory is that if we take those individuals who are misusing those services, or they're not getting what they need out of it, and move them away from it, what we've always spoken about, and we've had work that has been published or peer reviewed and published by the University of Essex, looking through a health economics model at the impact that it has on the individuals that we support. One of the things that we really want to look at is, that's great, and we can say, okay, for each of those individuals, because of their savings of GP visits, A&E visits, all of that stuff, there's effectively a save. In reality, there's not, because someone else just comes in and uses the capacity. The bit that we're really interested in, this is why we're talking to adult social care as well, is what happens in the space that's left behind as you move those individuals out of it. And actually, is that space, does that mean that more of the population gets seen sooner, so they're less ill when they get to the front of the queue? And we had an interesting conversation about that, and I have gone away and thought about some of the points you raised. And at the moment, we are talking to an academic institution about getting the funding to do that, but also looking at really what is that impact. What I've got one more video and it's only about 2 or 3 minutes long. I want to show you this partly because it is a video that will help you put yourself in the shoes of the people that come onto our programs. A lot of the people that come to us have really high levels of anxiety. What we try to do, and Jane was kind of describing it in that video, is try and remove all of the barriers to coming out to us or going out to another organisation. Because fundamentally, that's what stops these people moving forward, is the barriers that either they put in front of them or are in front of them. And one of them is overcoming their anxieties. So this is one of those ways that we actively do that.
Welcome to Frithie Woods in Lawshall, just outside Bury St Edmunds. Our day starts at 10 a.m. and we will meet you at the car park just outside of the Woodlands. You should spot a GLT sign and staff members in green polo tops. If you are driving, then please remember to put Frithie and Chadacre Woods into the sat-nav, not the Greenlight Trust, as this takes you to our offices. If you do not have your own transport, do not worry. We send a GLT minibus to B&Q in Bury St Edmunds and Roy's in Sudbury for a 9:30 pickup. This is completely free and takes you straight to Frithie Woods with a member of staff. Once we've all arrived, we walk into camp together. Each camp has its own fire and seating area and is surrounded by beautiful woodland that changes throughout the year. A typical day in the woods starts with a relaxing cup of tea around the fire, followed by a woodland walk or conservation activity. We then cook a delicious meal over the fire together and start a woodworking project in the afternoon. It does not matter if you do not have any experience in these activities. We will teach you everything and make sure you can do everything safely. The day finishes around 3 p.m. and if you caught the GLT minibus to us, this is the point where we will pack up and you are dropped back to B&Q. We have lots of activities for you to get involved in at the Greenlight Trust, and you can participate as much or as little as feels right for you. You can also spend some time in the hammock or sitting around the fire taking in the beauty of the surroundings. On the first day, we'll decide as a group what we should cook for the rest of the sessions. Different participants and staff will then cook together each week, and we eat together around the fire. There's no pressure to get involved with the cooking, but if you fancy giving it a go, it's a great environment to learn a new skill. GLT courses are a great opportunity to meet new people and get to know the team. We do lots of activities as a group, but if you need some time alone, we'll always support you. We offer various courses throughout the year, and we'll be happy to answer any questions. See you in the woods!
So that's kind of it. Hopefully from that video you can see how we use the activity to really subtly address things like people's dietary choices, their exercise choices, without actually saying to people, today you're going to learn how to cook. The other side of it is we have a pathway, and there's a proportion of our funding that comes out of health now, which we're very grateful for and is enabling us to reach a lot more people. But we're also funded directly by schools and adult education to create that whole pathway, really, that I've described and outlined.
That was great. Thank you. Maddie, do you want to say anything in wrapping before we go to questions?
I think Tom said it all. Thank you. So I think just to ask if there are any questions.
Yeah.
Okay, Tom, thank you very, very much. So any questions, colleagues? And Stuart, I wonder if you might have something to add here.
Yeah, absolutely. Thanks, Tom. I mean, this is life-changing stuff, isn't it? This is what we can do and what can happen when we think just differently, rather than focusing our energy on how services have been performing historically, what we've inherited. If we actually do what makes a difference to people, it is life-changing. You know, it's a pleasure for us all to be able to work with Tom and colleagues to do that. I think the challenge for us as a board is, you know, this could be relevant to so many people across our patch. It doesn't just have to be the people who have ended up in a position where they're so lonely, the only thing they can do is ring us at the small hours of the morning. There are loads of people across our counties who would really benefit from this. And this is exactly what we should be focusing on.
Yeah, and it's all about community as well, and re-innovating, re-energizing. Yeah, okay, thank you for that, Stuart. Andrew?
I think anyone that's been to one of your woods would say how inspiring and how peaceful it is. I certainly felt that when I came to visit. And I really enjoyed that presentation. It reminded me of some things I observed when I was there. Really interested to work with you perhaps on what models might look like for other long-term conditions, particularly ones where trust has been lost with health professionals, or where there's a fragile therapeutic relationship. I think that seems to be one of the great things you can draw out from people, so that there may be some really great opportunities. And also we spoke about a particular piece of research, but I think there are many research questions that could be answered in Greenlight Trust, and happy to help work up any further research ideas you've got, or potentially put other people in touch with you to discuss their research ideas, because it's really, excuse the pun, I didn't plan this, fertile ground for health services research.
Okay, thanks, Andrew. Thank you. I'll go to Ed and then Tanya.
Yeah, thank you, Tom. A brilliant presentation. I was keen to bring this here not only for the content, but it's an example of where we're now investing recurrently in the voluntary sector and in a partnership with the statutory sector, NSFT being an example. And it just feels to me we need to scale up and continue to do more of this, because the evaluation that Tom's shared shows the benefits to people, doesn't it? It's obvious, and the benefits in terms of the way we support demand in the system. So it's really important on a number of levels that we were able to illustrate the success of the scheme, because it would be great if we could look to continue to build with other voluntary sector partners in this way.
Yeah, that's a good point. And how far could we go with it? And then also, as Tom touched on, the future assessment of impact and so on being also so important. Tanya and then Stuart.
Thank you, Tom. Thank you for that. You talked about barriers for access to the service and how people are using it. What are we learning about those barriers as a whole system that can actually help address some of the root causes? Because your work is fantastic, but I think it's fixing. And I'm really curious as to what's underneath that and what do we need to fix on a much deeper level that we can learn as a system?
Yeah, good question. Do you want to respond to that, Tom?
Yeah, I can do. So I think the way that we've evolved as a charity, so the charity itself is about 35 years old, and it's really in the last 10 years that we've kind of concentrated in this area, and in the last 5 years that we've really kind of honed what we're doing now. We've always tried to maintain open access onto our programs, regardless of people having to meet a threshold or having to go through a route. Obviously, with funding coming through health, what is happening is we are seeing individuals being referred through. In an ideal world, what I would like to get to a place where we have an established pathway and people are able to come to us. I think there's a barrier of assessment prior to people coming in, and I think if we look at Greenlight Trust's potential to reduce or to support the reduction of waiting lists, I think we need to have a kind of open, frank and honest conversation about whether or not someone really needs to be assessed whether they come into our services, because through other sources of funding people can self-refer and we can be working with them, and we've got people who've come onto our programs and that has then led them to go into, say, drug and alcohol rehabilitation services and things like that. So I think possibly that's one barrier. The biggest, for us as an organisation, the biggest barrier at the moment is capacity, and the thing that dictates our capacity is the amount of funding that we have to deliver what we deliver. It used to be a few years ago, it used to be the sites where we deliver it. We don't have that as an issue at all. We've got more than enough sites and the ability to bring new sites on. We just brought a new one on out near Lowestoft. But it is that having the recurrent funding enables us to be able to say, actually, we can invest in that. The other thing that possibly didn't come through in the presentation is part of that recurrent funding is about us getting other organisations to deliver as part, so other third sector organisations to deliver as part of that pathway. So where we've got someone who needs, say, I don't know, money advice support, and that we bring another organisation in and then we fund them to deliver that. So yeah, Suffolk's rural and transport is a barrier as well. So overcoming, that's part of what we overcome. And fundamentally, if you talk to someone who will not engage in anything else, the reason why they say they come out to us is not because it's outdoors, and it's because we invested the time and they didn't feel like they had an excuse not to come. So effectively you remove all of those excuses and that person is then getting up. But when someone's in that rebuild phase, our participant engagement coordinators will phone them in the morning when they're supposed to come out, because we know they're heavily medicated and they won't be awake. So it's trying to overcome all of those barriers and create something that is truly person-centered and individualized.
I'll just hold you for a moment, Stuart, if I may, because I think Lisa wants to come in on this subject. So, Lisa.
Thank you. Tom, with that challenge, is there any potential for your kind of model of care to be affiliated with other community organisations to get into that kind of prevention space? Because your model and how you deliver it, which is to turn how that person has been treated often by services on its head and really kind of develop that personalised approach. But there's so many community organisations out there. I just wondered whether it's in your plan around how you can become an educator, a supporter, a developer of other community assets rather than always a deliverer.
I think we do support organisations that we work alongside. So as much as we work alongside statutory organisations, we work alongside other third sector organisations. We will help them to understand. In an ideal world, what I would like to be able to do is to model a way of working with the people that we work with, and to help other organisations to see how actually by modelling that they can better integrate with statutory services. So yeah. But we already do that. So we already operate in that kind of prevention space as well. It's just that example is more around that kind of crisis support.
Okay, thank you, Lisa. Stuart, sorry to hold you. Over to you.
Hi, Tom. So I think one of the bits around the evaluation side of stuff, I wonder whether the evolving population health management data set might be an opportunity to show the wider impacts of your interventions and actually comparing it to other cohorts that are not going through it and looking at, and that will have in there social care data as well as primary care data and other health services. So that might be something to have a conversation with Anne and Chris with at some point in my team, because I think that might give you an opportunity to have even more in-depth understanding of that wider impact. But I think actually just following on my second point was about the point that Lisa made, we were just talking about, and you, at the beginning you talked about the opportunities for VCFSE more broadly. And so on Thursday we've got an event here which has got art, museum and cultural organisations coming to talk about the work they do to deliver the outcomes that we're trying to achieve. And I think there are different models and different ways of working, but actually again I think some of this is about recognising what's already going out there, but necessarily as statutory organisations we're still not building on those assets as well as what we can do. And Tom's got a very clear and effective model, and I know the Greenlight Trust have got the data and all the rest of it. So I think there's learning across there around the evaluation side. But I also think there is coming back to those sector and working together about how we can build on the strengths they are already doing. And Tom's organisation is an excellent example within that. So I think it's about how we link into it, but seeing the wider ecosystem that's out there.
I don't disagree. I think the main point that I would kind of pick out from that is the need for both sides of the fence to kind of look and really truly say, actually, this is something that we're doing together, as opposed to that kind of. It feels a little bit like sometimes the both sides refer to it as an either or. So actually, we could give us that, and we can do that, or what you're taking away from what we do when you're doing that. Whereas I think this model very clearly demonstrates, and it takes a lot of work, it takes an awful lot of work to get that and embed it and have the right people. And the work that we're doing across CAMS at the moment, we're rolling it out slowly. So we're working with one area to then demonstrate. So there's a method of doing that in partnership, and I think that's possibly why the model is effective. But I don't disagree with what you're saying.
Yeah, thank you. That's a really interesting discussion. So Stuart and Stuart Keeble and Stuart Richardson. So I didn't realise you were sitting together at that moment. Yeah, I'll have to think about the seating next time, won't we? And Lisa, and then I wonder if there's any advantage in picking up with NIHR the point that you made, Stuart, about looking at future data sets or past and future data sets, and the point that Tom was making about investment in future assessment and evaluation. But is that something that perhaps as a team, the ICB, the County Council, NSFT and Greenlight could pick up outside the meeting to see if that is a possibility? Yeah. we'll take that as an action. Okay.
I
Happy.
think Andrew
Oh, and
will be
Andrew
better
as well.
to-
Yeah, sorry, didn't mean to exclude you. In fact, we'll definitely add
He's
you
already
in.
having the conversation.
Oh, are you? Oh, right. Oh, didn't realise. Apologies. Fanwell, over to you.
Thank you, Chair. And thank you, Tom, for that presentation. I think there's also something outside of the kind of sort of high intensity interventions that I think we saw post pandemic people coming forward with the challenges that they, particularly those who didn't have that access to nature and access to and some of the conversations that we've been having is really how to encourage more people access to that. I suppose my question is around and it's a question really open to everyone to say if there's this ample evidence that this is something that really drives positive change and looking at it from a preventative approach, what can be done for some of those cohorts who are not at that sort of high intensive level, people who just want to access nature, who, that access can actually help prevent sort of getting into that. Is there something within your provision that sort of avails, your service to everyone?
So I think we're really clear about, as an organisation, we're really clear about who we support and the work that we do. We work with partners like the RSPB and National Trust for that wider population access, and that's why we deliver. I think the bit that's missing within all of that is an understanding of what is required. So if we look at Ipswich as an example, so we know that socioeconomic standing of an area influences the amount of canopy coverage, of tree coverage across that area. So we know that the poorest areas in Ipswich are the least green areas. Those things need to be fed into planning, and those things need to be fed in through, and it's a conversation of actually we're featured as part of the ICB Green Plan. And those are the areas where you can influence on a landscape scale and address some of these inequalities. There's some really interesting research in a guy called Julian Agyeman who's doing some research in Boston at the moment, and actually looking at where you have distinctly different ethnicities in two areas, and actually creating high quality green space in between those areas brings people together to interact where you have these kind of lines. So there's a massive amount of research, and I think it's an area that I would be interested in us having more input from a kind of health impacts, but I don't think we're the organisation to do that work. I think with the work that we're doing, we are the organisation to do that. But yeah, we can definitely have influence and guidance over what happens in that area.
Okay.
Thanks.
It might be something that I know Stuart and I have talked about this in the past, but worth picking up with the university, because it's often the same areas that are suffering from the worst air quality, isn't it? And yeah, these things are so interconnected, aren't they, in every respect? Great. That was really good. No, I don't see any more questions, Tom, from the board. Oh, I do see one now. A quick one, Susanna?
Really quickly, so building on the comments that Stuart made, Stuart Keeble, just want to say that I think there's sort of two dynamics really. I mean, there's something about the relationship with statutory sector partners, which is obviously working really, really well here, but also what's come through this conversation is the relationship with other community organisations. And, there's been a lot of work recently around our resilience charter as a system. We've got about 100 colleagues involving about 50, I think it is, close to the voluntary sector. So what would be really good to play into that conversation would be those principles now that we've agreed as a whole system, and start to see how we can really make those work to, as you say, kind of scale up these sorts of approaches, because I think they work well, obviously, the outside areas, but also culture, heritage, as Stuart said, and lots of others. So it's got so many assets, we don't use them enough, really. So that'd be helpful.
Great, thank you. So, Maddie, thanks for bringing Tom to the board meeting. Tom, thank you for coming.
Thank
I
you.
hope that you can see that you've got the passionate and enthusiastic support for the work that you're doing and the impacts that you're making on our people and population, for our people and population. So thank you for everything you're doing. And I hope that that message of continuation, keep going and keep making those impacts from the board have come over to you clearly.
Yeah, that's great. Thanks for giving me more than 17 minutes.
Don't worry,
Much
don't worry.
appreciated.
I'm going to steal some back now from others. So thank you for that. Okay, thanks everybody. Right, so let's move on then to items 8 and 9. These are both the Set Mental Health Strategy Collaborative and the Suffolk and North East Essex JFP. They're both down for Richard, but Richard had a better event to go to, shall we say, today, and Ed is picking them up. But I know that Ed's going to ask us to treat them as, if you like, as read. But Ed, over to you.
Thank you. So I think both items have been trailed in the board before, so they shouldn't be a surprise. So the first one is the Southend, Essex and Thurrock mental health strategy, which in essence is a refresh of a previous strategy from 2017. There's been through the Tricordant agency who supported, there's been a lot of engagement with many partners, including the public, and it's an all-age strategy guided by I statements in terms of what matters to people. So there's a very clear vision around good emotional and mental health for everyone, reducing inequalities and living well in general. And there's a clear set of actions on what is needed and what will be taken forward. I think it kind of reflects the philosophy that an approach that Tom has just shared with us. This is really around doing more outside of an acute context, more early intervention and prevention, and building on the assets that are in Essex to support mental health and emotional well-being. The second bit around it is obviously the implementation, and whilst there isn't going to be, I don't think, a formal mental health collaborative across Southend, Essex and Thurrock, there is going to be the equivalent implementation group, which will be hosted by Essex County Council and chaired by our very own Richard Watson. So that group will be overseeing the implementation of the strategy and ensuring that there's an inclusive approach, particularly across the 3 councils and the 3 integrated care boards in Essex. So we're asked to endorse the strategy and secondly, support the establishment of the implementation group chaired by Richard. Thank you, Chair.
Thank you, Ed. Any questions or points for Ed, or indeed any other colleague around the table? Otherwise, we note that we've seen this during its gestation many times, that we've debated before. We're happy. We'll thank all those who've been involved in this work, which is a big piece of work and widely integrated across a number of systems. We're happy to endorse and support the strategy, and to support the strategy implementation group establishment under Richard's chairmanship. Everybody content? Agreed. Thank you very much, Ed. I'm going back to you for the JFP item.
Thank you. So I think this item and document will be familiar to the board. We had a recent board development session on it. I know that Richard and colleagues has taken a very inclusive approach to the development of the plan, and I know that various partners have drafted the relevant sections where they're expert in. The joint forward plan has been to both Essex and Suffolk Health and Wellbeing boards, where it received, I think, warm support. And the plan has been organised around our 6 Live Well domains, which begin with Start Well through to Die Well, and all of the work in the alliances are now 3 alliances are organised around those domains. There's been a common methodology in place, largely organising, constructing the document around why an initiative is important, what it's trying to achieve, and how it will make a difference. And there's a set of top commitments to deliver in 5 years for the Integrated Care Board through to 2028. These commitments have been based upon public feedback through the engagement process we undertook, and similar process that Susanna undertook for the ICP strategy, partner engagement, JSNAs, integrated care partnership strategies, and the NHS long-term plan. So I think this is the final step on a journey of this plan. So we're asking for the board to approve it, and then we get onto the more difficult aspect, which is the delivery of the plan.
Delivering it, yeah. Okay, thank you, Ed. So again, noting that you have seen this as board members, you've seen this many times through its iteration and worked hard, I know, with colleagues in its development, that both our health and wellbeing boards have enthusiastically embraced the JFP as presented to you. Are you happy to endorse and approve the final document? Everybody agreed? Marvellous. Approved. Thank you very much, all. In which case, item 10, digital and care technology services. Andrew, all yours.
Thank you. The paper, again, those of you that were in part 2 will have heard a little bit of this already, but the paper, like many digital papers, sometimes can be quite hard to get into. And I wanted just to give you a readout of what I personally think the key points are. You may have other things that you've read into it you'd like to ask questions on as well. Firstly, this is in response to a question that was raised when we were talking about Cassius a number of months ago. And we recognised that there was potentially a gap between the digital data and technology work happening in social care services and that happening in the NHS. We wanted to close that gap. So as part of that, a review of the landscape was conducted by Joe Lennox, who's our acting digital programme director, and Sam Bassett, who works for Suffolk County Council on behalf of both Suffolk and Essex County Councils. So he was nominated by both county councils to do this work. The review is in the board papers, and that's what I'm talking to. There was an explicit recognition that within that review, the alignment of both the clinical and care strategy and the transformational strategy with the digital strategy was vital to progressing the advancement of digital data technology in health and care settings. And actually neither strategy was effective in isolation, and both of them had to work together. And also fundamentally, no single strategy had supremacy. So they really have to work hand in hand. And often we think the digital work's got to be nested within the clinical work, or the clinical work's got to be nested within an overall digital strategy. Actually, both statements are true. The progression of digital change in our system is critically dependent on the behaviour of people. So, you know, we often talk about fancy digital apps and new technologies, but actually it comes back to fundamental tribalism and the way in which we interact with each other. And therefore, the advancement of any digital programme is critically dependent on us investing in both culture of our people that we work with and our organisations as well. And that came out very strongly as part of the review. Some gaps in governance were identified around existing digital initiatives, including the ownership of digital initiatives was often distributed, that there can be competing and sometimes overlapping priorities, that benefits realisation wasn't always conducted for all digital innovations, and therefore we couldn't always be sure how effective and how worthwhile that innovation had been. And there were gaps in both the commissioning and the decommissioning of digital initiatives across the system. There are multiple ways in which we can align digital opportunities and digital programmes in both the care sector and the health sector. To try and realise these opportunities, 7 recommendations have been made as part of this review, and they're listed in the pack. But they all actually describe ways in which we might strengthen governance for whole system working in an increasingly digital world. And I think if we think about it in that context, they make an awful lot of sense. So what's being proposed is through existing relationships that we build a strong collaboration between the NHS and social care sectors, and increasingly, as Ed referenced earlier on, with higher education institutes as well, very much linked to the market, which includes the voluntary care and faith and social enterprise sector as well, to implement these recommendations. And that's going to be at the forefront of our digital programme work going forward. So what I'm asking as part of this paper is that this committee recognises the complex and fragile nature of the digital world in health and care. We've already committed as a board to undertake some development, and a board development session is planned in collaboration with NHS providers for the 24th of October this year. Thank you, Lisa. Lisa's vote of confidence there. But I'm also asking you to endorse the recommendations that have been made in this review and support them through your individual partner organisations. Thank you.
Thanks, Andrew. Very helpful. Nick?
Somebody just said Nick and digital. That's not been said in the same sentence before, but we'll give it a go. Really welcome the work, and thank you for that. I suppose, and it wouldn't sit with this group. I just wonder where we're picking up the issue around digital maturity and digital austerity for people that use our services, because as we move towards, rightly so, for all the reasons that you talked about, a more digital approach to caregiving, whether that's in third social or health sector, how do we ensure we don't leave people behind? It may not be for now, but I just wonder as a board where we're picking that up.
It is to an extent picked up in our Digital Investment and Assurance Committee on the back of a piece of work that our previous digital programme director did, looking at the ethics of digital initiatives in health. And actually we were one of the first, and I think still one of very few integrated care systems that have started to articulate what ethics looks like in digital health and work alongside those principles. But there remains an enormous gap, and we often talk about our deprived communities in this committee, and there's no way of pretending that access to digital solutions is not hard for them. We have to keep it, I think, everywhere, but it is led through our digital committee. I will take the opportunity, however, to big up a different definition of digital maturity. So we were asked to complete a digital maturity assessment for NHS Digital this year, and we did very well out of that. And as a system, we scored 2.8 out of 5, which will be meaningless to you as a number, but the national average was 2.6. So we've done better than the national average, and the only ICS in the East of England to do that. So all credit to the work of the digital team towards that.
Okay. But to summarise Nick's point around digital exclusion and inequalities and so on, what you're assuring the board is that is very much on the committee's agenda.
That's correct.
Yeah, great. Okay, thank you. Stuart?
Actually, I was going to come in on a similar point. And I suppose the question is that whenever we present anything like this, we kind of need to have the two of them side by side. As a reminder, so we've talked about, as a system, we're going to have the Health Inequalities and Prevention Board, and about how we embed inequalities more broadly. And so I suppose it's that difficult thing that we've focused here on, particularly that piece of work, but I think it is something about how those two things are side by side in those conversations in that sense. And I also wonder whether we know some great work's been done by the system, by Healthwatch, around some of the digital standards about what we can do. But obviously we've got other system groups. So we've looked at health and social care coming together on the digital delivery. What about some of those wider forums about how we're doing that? Because you say there's wider issues which are driven by poverty and other factors of access to digital solutions. But is there anything else we can do more collectively around some of that as a system more broadly?
I think I understand the question. Is it how do we deal with digital inequality more broadly across the system? Is that, have I misunderstood?
So I think there's two bits. One of them is that we've got this paper here today, but I think it would have been good if we had digital inclusion within that. So we're always seeing these concepts side by side. Because if not, we go down the technical solutions without thinking about the impact around that. And the second bit is that are we maximising the opportunities across the system around tackling digital exclusion more broadly, coming together? So I know that there are different communities of practice sometimes across health and across the wider local authority. So are there opportunities to try and bring and strengthen that learning in the same way that you've come across health and social care with looking at your digital approach more broadly?
Yeah, so in answer to the first part, yes, I completely agree. It would have been good use of the opportunity to do both at once, and that's a gap, I suppose. In answer to,
could we take it that will go on to the the agenda?
Well, yes. So there's as part of the workshop that's planned to advance the work that's described in this paper, I think we can quite easily bolt in a conversation about digital exclusion as well, knowing that it happens. As part of the broader piece of work you describe, I think that's one for all of us to take back to our respective committees and groups and ask the question. So I would put that out to all of us actually to do that work.
Yep. Okay, thank you. I'll go to Kirsten, then Susanna. Kirsten.
Thank you very much. I wholeheartedly agree with the points made on digital exclusion, so I won't go over those again. What I want to focus on is the voluntary sector. Very happy to hear you mention them in terms of this work. I think if the voluntary sector were included and maybe bumped up the priority list for looking at how we can work together with the statutory sector and share data and digital, sort of digital mechanisms, we would be able to see much more clearly how well the voluntary sector contribute to prevention and other pieces of work that are going on and that we want to encourage. One of the things that really holds us back, and I think Tom articulated how well some organisations can do it, but smaller organisations really do struggle with being able to present data and information in the way that the statutory sector can really understand it and use it. So to be part of this sort of work at an early stage would really, really assist. And I think we'd be pleased to see the sort of data and information we'd get out of it.
So there's an opportunity there. The Department of Health and Social Care really recently invested an awful lot of money in developing digital technologies in social care, particularly data and talking and communication from a digital perspective, with pilots being invited with investment of up to £600,000 per pilot. I think we should explore whether we can answer some of the questions you've asked through one of those pilots, perhaps through a voluntary sector organisation that's linked into the social care market, because it may be one of the few places where that question is being discussed. So there's a big opportunity there for us as a system to get ahead of the game.
Thank you, Kirsten. Will you take that as an action, Andrew?
I will.
Thank you very much. Susanna.
So I'm building on the points from Stuart and Kirsten and just make a suggestion, which is that we did make really good early progress in terms of undertaking a comprehensive quality and health and equality impact assessment of the digital programme. We also, the work by Healthwatch that set out really helpfully a set of principles around digital inclusion. And then the kind of, early links with the voluntary community sector through what's now our assembly. I just wonder whether we should challenge ourselves to kind of do a bit of a review now, because as Stuart said, it's really important that we track not just delivery of our digital programme, but how are we doing in terms of delivering against those issues. And we've got a framework to do it from that early work. So perhaps we should sort of, make a note of that now to get through that review and challenge ourselves to say, are those things working for us around that process, and what can we learn to apply to other programmes' work?
So a milestone check, as it
Yes.
were. Yeah, you happy with that?
Would you help me with that, please? Thank you.
Okay, that was she said yes, so that was well done. Thank you very much. Any other questions or points for Andrew? Otherwise, we're asked to receive a note, and then I'm not going to read them out. You don't need me to. They're on the paper before you. There are 7 recommendations that we're asked to endorse. Is everybody content to endorse as requested? Done. Thank you very much. Thank you, Andrew. Thank you. In which case, item 11, the ICP update. Susanna.
Okay, so I'll be brief. There's a brief report in your papers with an update from the Integrated Care Partnership. In that, you can see a breakdown of the last meeting of the ICP formal meeting, which took place in April. And some of those issues have been picked up in today's agenda. One of the key decisions from the ICP in April was that the ICP approved a number of areas around measures for our integrated care strategy. So a suite of barometer measures, which we're now incorporating into our integrated care strategy, which of course is held online as our ICS website. So those barometer measures go right across the key areas of our integrated care strategy. and are really aimed at how we can kind of assess our progress in terms of, as a whole system, make a difference to the outcomes for our population. Also really important around that, underpinning that, was an ICS measures framework, which the ICP approved. And that's important because we measure a lot of things and we describe those things as different things, but this really clarifies what's a performance measure, where we're measuring a benefit that perhaps we deliver to the population or a subgroup of the population, and where we're measuring outcomes and indicators of outcomes at population level. So that's been very key step forward for the ICP. Thank you to Ed for already his advertisement for our Can Do Health and Care Expo 2023 event, which will be, as Ed said, on this Friday, the 7th of July at Worsted Park. I'm going to be chasing everybody in the system for their final contributions in terms of stalls and workshops and all of the content for that programme. We've held two key events as an ICP in the last few weeks. So thank you to Fanwell, who chaired our ICS system learning event around a community-powered NHS. So this was an event that we organised in partnership with an organisation called New Local. They published a report on a community-powered NHS, which attracted quite a lot of interest nationally. And it really, really underpinned, in particular for me, the importance of the work around that voluntary community faith social enterprise resilience work that I mentioned earlier on. We've heard how important that is this morning from hearing from colleagues from the Greenlight Trust, but it really, really underpins the importance, as I said, both that relationship between the voluntary community sector and statutory sector, and also how important it is to build those relationships between voluntary community social enterprise sector organisations as well. And then more recently, on Friday the 12th of May, around 70 leaders from across our system came together for an away day where we took time to reflect on learning from the winter just past and some of the considerable pressures that our system experienced at that time. So we heard from, in particular, frontline staff, colleagues from public health who presented some really very interesting and challenging data about the story over the winter. And also from a number of providers, including a lot of clinical input, who presented ideas for how we could do things differently. We're currently writing up both those events, and of course we will publish the write-ups of those events so that they're available. Which brings me on to my last point, which is that obviously if you go to our ICS website, it sets out a number of ways in which colleagues can get involved with the work of the partnership, which is at the heart of our integrated care system. But we were really pleased that the HSJ recently took time apparently to look at every ICS across the country and to look at the work of ICPs, whether those ICPs were meeting regularly, meeting in public, and also sharing their work published online. And SNE ICS ranked top in the country according to their rating in terms of the number of meetings and the availability of that information in public. So thank you very much.
Thank you, Susanna. Any questions for Susanna? Otherwise, received and noted, and keep going and stay top. That's the board resolution. Okay, well done. Thank you very much. In which case, let's move. You probably noticed I just had a quick word with Ed and I said, do you need a coffee break, Ed? And he said, no, crack the whip. So we're cracking the whip at that. Yeah, I know, it's hard life, isn't it? In which case, I'm going to go on to item 12, which is the ICB financial plan. And Howard, we're in your hands.
Thank you, Chair. So just to be clear, I guess when I use the word system in this context, it's the NHS organisations within SNE, of which we are expected to deliver an overall financial balance. So those organisations are the ICB, ESNEF, West Suffolk Foundation Trust and DE East. And I think before I go into the financial plan, I'm also pleased to report that subject to audit, all partners within the NHS SNE system delivered on their financial plans for 22-23 with a small surplus of £128,000. And that's consistent with previous reports I've made to this board.
So the 23-24 planning paper, which I'll take as read, just pick up some of the key elements, is comprised really of two parts. One is an update on that system-wide financial plan. That's for noting. And then we have the ICB financial plan for 23-24, which is coming here for approval. And those plans have been scrutinised also at the ICB Finance Committee. So first of all, for the system financial plan for 23-24, in line with the national timetable, SNE system presented a balanced financial planning position. We were in fact one of the first in the country to do so in what has been a very challenging planning round for the whole country. Within this included a cost improvement plan requirement of 3% or 62 million. So that compares with a regional average of around 4.5%. That is important because it's one of our indicators of credibility of the plan. So that would indicate we're at the lower end of risk compared to other systems within the region. However, the system itself has an overall £52 million underlying deficit, and that means that we've effectively been balancing our position over the years by non-recurrent means. And whilst that plan may be credible this year, eventually we will run out of road potentially, and that will materialise into a deficit with all the consequences that go with that. Amongst the partner organisations, West Suffolk Foundation Trust put forward a 2.7 million deficit position. That's after receipt of £7 million of non-recurrent support from system partners. And that was offset by an equivalent £2.7 million surplus with the ICB, both East and ESNEFT presenting break-even financial positions. And the West Suffolk Foundation Trust deficit position is underpinned by a 15 million underlying deficit. That's part of that 52 million, which at 4%, or just over 4%, is the highest in our system, proportional to turnover. So clearly improving our underlying position of all partners in the ICS is going to be a key priority in this financial year and over the coming years as well. And just wanted to say that the ICB Finance Committee is going to play a role in year and how we're monitoring and also improving our sustainability as well as making recommendations to the board and bringing an enhanced set of terms of reference that will describe that to this board in July. Finally, just on the system, I really want to acknowledge the absolute professionalism, drive and determination of the SNE finance community. It's really exemplary. And to the extent where that determination materialised in the development of a £3.9 million health inequalities fund, which is going to be governed under Stuart's chairmanship through the Health Inequality Committee. And I think we're really fortunate in SNE to have that opportunity. Not many other systems, I think, are in the same position. The second part of the paper is the ICB financial plan. In this context, I'm talking about the legal entity that is the ICB, and it has a total allocation of £2.08 billion, including just under 90 million for administration or running costs. And that plan is coming here today for approval. There's going to be a further paper presented to the June board for approval of the formal delegations down to directors and committees. We're just completing some of the internal governance on that. I just wanted to remind the board that the ICB has certain legal duties. The first is that we need to spend within our resources, and that includes our running costs. In addition, the ICB has to meet a minimum level of financial growth for mental health services. That's known as the Mental Health Investment Standard. And for this year, it's 7.1%. This plan meets those requirements. And the ICB, as I've just said, is planning on delivering a £2.7 million surplus. That's to offset that 2.7 million deficit, ensuring a balanced financial position. And I think I just wanted to highlight really the two key elements of the plan that allowed that surplus position to be made. One is we made decisions very early in the planning round about withholding approximately 14 million of investments and services, and we're also required to deliver a 13.5 million pound cost improvement plan on our influenceable spend, which is predominantly prescribing, continuing healthcare and our sort of corporate budget areas. We have set aside contingencies against our cost improvement plan, and I'm hoping we'll be in a position to be able to release some of that for investment, subject to greater confidence in our delivery, and we'll be keeping a close eye on that, making assessments as we go. With regards to our cost improvement plan, at this point we have approved just under 12 million pounds of our 13.5 million target, and we've got another just under 4 million of plans either in draft or being scoped. And I think we have reasonable levels of confidence in delivery of some 11 million of our total program. And again, we'll be paying particular attention to that over the course of the year, and that will be through our financial recovery sustainability group that will also report into the finance committee. And I think finally, just to say, there are risks obviously within this plan, probably the most significant being linked to unplanned inflation materializing and delivery of our SIP plans, again, both of which were set aside a reasonable level of contingency, but we'll need to keep a close eye on that. And of course, we'll see what happens, I guess, with the inflation picture as we go through the year. So just wanting to recommend to the board that we approve the ICB financial plan to deliver a 2.7 million pounds surplus for 2023-24.
Howard, thank you very, very much. So, any questions, comments? Steve?
I mean, everybody who's been involved in these things know how arduous these tasks are. It goes on and on and on from month after month. So well done to the team, particularly the collaborative activity and behaviour that we've seen on our behalf. It's really good. And for our, we delivered collective break even by some doing a bit more than others, and on this occasion, time for something else's turn. That's the way we want to see things done. I just want to plea, and I'm happy to agree to sign off what we've got. One plea that as we go forward in our conversations over the next however many months it is, remember to focus enough attention on the cost improvement programme, not the management cost reduction. That's going to be the big thing that's going to, external parties will be batting on about whether we're doing that stuff to get 9 million over 2 years, I think it was. There's 60 million in question in the cost improvement programme collectively, and we need to give that 6 to 10 times more attention than the other package.
Yeah.
Because it's difficult to do so because the external parties are always interested.
And appropriately early in the cycle.
And so that's the, for the finance committee to get its teeth into.
Do you want to comment on that, Howard? Completely agree. We'll record that. So thank you very much. Thanks, Steve, for that supportive comment. Nick?
Thank you. And again, I'd echo the way that the finance community has come together. It's reassuring. I suppose also just on that there has to be, I think, for the whole system to feel the same robust approach to CIPs right across the whole system, because I think that, as you say, there will always be some perceived winners and losers when you work in the system. I say perceived because it may not be the reality. Just a question on the ICB CIPs. Could you just give us a brief outline about the quality and equity assessment that's been done in terms of developing those CIPs and how they've been signed off?
I think that's a good challenge on the EQIAs, so I don't think we've completely battened that down at this point, to be completely honest. But we have sort of set up a process where we're going to start doing that.
So would it be fair to say, Nick, that you'd like to see those come back to board when complete?
Yes.
Good. I'm glad you said yes then. Thank you.
Actually, no. I think we've got to trust the committee process, haven't we? So I think there's always going to be that debate about what comes back to what stays at committee. I suppose it's just the assurance at the board that that process does happen at committee stage. I don't think it would be appropriate to go through them all, but it's always going to be that debate around assurance.
So as long as the assurance is there that it is in process and complete. Happy? Yeah. Good. Thank you. I'll go Ed and then Andrew.
I'd echo Steve's comments. So my point is kind of the obvious one, I guess, is that if the 4 NHS organisations described keep financial discipline and keep financial balance, we can then invest in models like the one that Tom presented to us and others, invest in prevention, invest in the community, in primary care, which is what we need to do for the population. Systems where they've lost financial discipline, whether it's in the commissioner or in the provider sector, are then in the position where they're withdrawing funding from prevention and upstream early intervention. So whilst we might focus on 4 organisations, the implications are huge for the community. So it's just so important that we keep the discipline, which we've seen year in, year out for a number of years going forward. And as you said, Howard, there is an underlying deficit, and we will run out of road if we don't tackle it. So it's really key that whilst we've performed relatively well, we're still a long way off where we need to be.
Okay, thank you, Ed. Andrew?
Lisa and I briefly conferred, and Howard, we can undertake to review quality impact assessments in quality committee, if that'd be useful.
Okay, thank you. Any other questions or points? Otherwise, we're asked to approve the financial plan as presented, whilst noting, I suppose, building on the points that a number of you have made, Steve and Ed in particular, but all, that we've got a lot of risks still to mitigate, and they are being mitigated, but the focus on that mitigation must be complete and continuous, that we work with system partners towards the sustainable underlying financial position, that we keep that focus on SIPs and the timeliness and the impact thereof, and that we formally approve, or the work is still required to formally approve the budget delegations to directors and committees. With those notes, is everybody content? Agreed, approved. Thank you very much. I wonder if the next item, which is you, Paul, for the performance reports, I wonder how quick you can be with this. If we're going to have a coffee break, how are colleagues doing? Are you okay to continue at the moment? I'm just conscious that sometimes a break is needed. Are you happy to keep going? Yeah.
I'm happy to keep going, Chair. I guess I'm looking towards Lisa and to see if there was anything in particular in terms of quality you might wish to pick up. I can be relatively quick with the paper, except for that exception.
Okay, keep going then, Paul.
Okay. So thank you, Chair. I'll take the paper as read, but if I may just pull out a few things. So first of all, you'll notice that in the agenda, a few of our names are agenda. That was part of an ongoing conversation at board part 2 to say we probably need to spend a bit more time on some things like quality issues and such like. So you will see within the report there is also an additional quality section that my colleagues may wish to pick up on as I finished talking. Just very, very quickly, clearly performance is reviewed at the System Oversight and Assurance Committee. They have nothing to escalate to this board in terms of particular issues, although there are plenty of challenges. But I'd like to point you to a couple of things, if I may. We had a national team visit relating to elective recovery led by Tim Briggs nationally. And they reported to us that we were a significantly mature system, and we had a great level of collaboration on the system, which is great news in terms of elective recovery, and we're clear to pointing that out to us. So they were happy that given the challenge that we had, we were working very effectively as a system to try and recover our elective activity. So I think that is a really positive sort of move, really. In terms of tiering, and that's something, a term that may not be familiar to folks around this table, but there is a new form of assessment, if you want, nationally, which is called tiering. And essentially there are 3 tiers. One where it's identified whether you are an organisation or a system that requires national support, or tier 2, which is again an organizational system that requires regional support, and tier 3, where you are deemed to be self-managing, and actually people are relatively happy that the plans you've actually got into place. So you'll note within the report we have a couple of tier 1, 2 that affect our acute providers. Just received in writing only the last couple of days that we are in tier 3 for urgent care, which is again a good news, and is also likely to affect cancer and primary care as we move forward. So just to flag, there is a new way of sort of engaging to how systems and organisations are doing in particular. The other point, and it's already been trialed by Ed, we had our quarterly performance review. The good news is that we remain in segment 2, which gives a certain level of accountability, with a willingness to talk about what it would take for us to go into segment 1, which actually the top performing in terms of assessment with our regional colleagues. So again, that conversation is ongoing, and as Ed has already pointed out some of the challenges around 65-week recovery, outpatient transformation, and in particular our C2 recovery in terms of ambulance conveyancing target. And we've already heard about some of the collaboration that is taking place around our urgent care and ambulance services. Finally, just very quick points. Within the report, as you know, there is a segment which is about operational delivery. We have recently published and actually given nationally our performance metrics and what we expect to achieve, and submitted as our plan nationally. That plan, as I understand, has been approved, and you'll see that within the report we are now to set out the various KPIs and measures that we are being managed and performance managed against for people to see. As time goes, clearly the performance data will feed through those targets, and that be visible to the board should they wish to comment or provide any focus and attention. And lastly, and probably the most important point, at the last board there was a discussion around whether we could give greater clarity in the communication to public and to the board in terms of some of the key aspects and areas to focus. And you'll notice in page 215 of the document, there is the first attempt to say, actually, what are we doing well? What have we done not so well? What are our focus area, which hopefully starts to give some greater level of clarity and simplicity to the message we are trying to give. I've asked the team to reach out to Healthwatch colleagues as well on the back of that, following the comms team's input into this process, and I'd welcome any comments whether that works or not, and I'm happy to change it or alter it if it doesn't. I'll stop there and happy to answer any questions. Thank you.
Okay, so any questions for Paul before I go to Andrew and Lisa? No questions. In which case, do you want to pass some comments on the quality item?
So very briefly, I mean, the highlight report contains some key narratives. There's two things I want to draw your attention to. One is that we have recently agreed in our quality committee an accountability framework which generates collective accountability, which we think is really important towards providing quality assurance at a system level, bringing all system partners together. And if there is agenda space, we would like to bring that to a future ICB, because we think that may inform other work across the system. The second thing I want to draw your attention to is safety culture. I personally, and I think this view is shared by other people, I personally think that the organisational culture is one of the strongest predictors of whether safe care is provided in the organisation. And the NHS staff survey, which is published annually and is in the public domain from 2022, identified that 49% of respondents, that's people that responded to the survey, somewhere between 40 and 60% response rate in organisations. So across the system, 49% of respondents were not confident their organisation would address safety concerns if they were raised. And 32% of respondents were not confident even to raise the concerns. That doesn't take into account primary care, because primary care is not included in the NHS staff survey, and it doesn't take into account social care. And there may be better or worse safety cultures in both those places. But I think that's a factor that we have to be very aware of as a board, as being important. It forms one of the main pieces of work that we're trying to address through the System Quality Committee. And it may be something we have to come back to in future boards.
And thanks for making that point, Andrew, and also for emphasising, as you did at the beginning, it's all about culture, isn't it? getting and maintaining the right culture. Okay, thank you. Lisa, did you want to add anything? You done? Any questions? Otherwise, we're asked to receive a note. So received and noted. Thank you. Amanda, I wonder if we could do the bath and then maybe a short break might be appropriate. Should we see if that works? Okay, so item 14, Board Assurance Framework, over
Thank
to
you.
you.
Thank you very much, Chair. So here we have the May Board Assurance Framework, and colleagues will note that we had a really good board development workshop on the 18th of April, and our BAF and current approach was one of the items for discussion. And from that board development session, we've taken a lot of the actions from that and incorporated into the version that we have today, but there is further work. And we've been working very closely with Susanna and her team on how we can combine the partnership into our board assurance framework. So we'll come back to that in a moment. But in terms of taking some of the outcomes from 18th of April session, we've tried to be more focused on our strategic risks and reduce the number of risks. So colleagues will recall we've had upwards of 20 risks previously. This time we've looked really hard at condensing and focusing on the key strategic. And for the May framework, we have identified 11 strategic risks. Some of the previous risks haven't been taken away or forgotten about. They've either been amalgamated to make it more meaningful. So some of the risks will be extended for our BAF. Other risks we've actually refocused and are now on the Directorate risk registers. So no risk has been forgotten, I think is a takeaway message there. In terms of the current risks, we have actually revisited all of the risks as we do each time, and the cyber risk was previously rated at 20. That has now been reduced to 15, and Andrew may want to say a bit more, but as we can see, that as a result of an MFA, a multi-factor authentication, which was introduced. So that's part of why that risk has been mitigated downward. We've also included a new risk this time pertaining to the consequences of climate change. That's something that we're working with Andrew and the system on going forward. And in terms of risk appetite, we've mentioned this previously and through the audit committee, but we've now actually incorporated risk appetite into our risk management policy and organisational framework. So going forward, we are currently, as I said earlier, working with Susanna and her team on the partnership, and we want to at least update the audit committee at the beginning of June as to how that may be presented so it's more combined going forward. And then what we aim to do is at our July board, come back with an updated, refreshed, revitalised, all-encompassing risk framework, which incorporates the board and the partnership. But we also want to include the BOF, the Board Opportunity Framework, that Andy challenged us rightly in January. So there has been a lot of work going on behind the scenes that we want to introduce moving forward. I'm going to pause there, Chair, but invite Susanna just to say maybe a word or two on the partnership work that we're doing.
So building on a really useful conversation that we had as part of the kind of recent away day, what we looked at was the kind of broader role of sharing information between partners, the system around building kind of trust, and also that sort of understanding of how we work as a whole system. So some of the key areas that we've looked at are that we could share high-level information. Bless you. For example, we have really useful dashboards around finance, around workforce, around performance, but also looking more broadly, Andrew just mentioned a number of kind of key barometer measures around kind of quality, for example, that are available. And similarly, we've been exploring some of those with colleagues from social care as well. And what we were hoping to do was to kind of build a sort of a suite of kind of short dashboards that could be shared on a quarterly basis with broader ICP partners for discussion through the ICP, which will give a kind of bird's eye view, if you like, of kind of system assurance issues.
Okay, That's helpful. Thank you. Any more, Amanda? Open for questions. Lisa?
Thank you. Just to update risk 21, which is the risk that is currently on our risk register around our 5 special education schools in North East Essex not having access to the universal school nursing service. We're transferring it to Essex Send Partnership Board because it's a Public Health Commission service. We've raised it with Public Health, and the SEND team in Essex County Council have agreed to transfer the risk to their risk register. Thank you.
Thank you. Any other points or questions? Otherwise, we're asked with that. When will that kick in at the next iteration, Lisa? So with that amendment, we take it as it is at the moment, but with that amendment to come, is everybody happy to approve? Approved. Thank you very much. So, okay, I've got 17 minutes to 4 here. We're actually a little bit ahead, but we mustn't be complacent, must we? Shall we take a 10-minute break and come back at 7 minutes to 4? Is everybody? Oh, it's 6 minutes now. Another minute's just drifted past. 6 minutes. It never stops, does it?
Yeah.
6 minutes. 6 minutes to 4. Okay, 10-minute break. Thanks, everybody. Right, 1 minute, everybody. 1 minute warning. Okay, everybody, how are we doing? Are we ready? Thanks for being prompt, much appreciated. Item 15, reading the signals, maternity and neonatal services in East Kent. Lisa.
Thank you, thank you. So we are required to ensure that the board has had an opportunity to consider whether it's assured by the system's response to the Kirkup report. So just as I'm sure many of you have read the Kirkup report, but it was a report into maternity and neonatal services at East Kent University Hospital. It was reported in 2022. The inquiry reviewed 202 patients' care and concluded that 97 of those patients could have had different outcomes if national standards had been applied. It found that teams were dysfunctional within that setting, lacked professionalism and compassion, and that the service failed to learn from incidents and concerns voiced by families. And it found that the Trust Board failed to respond adequately when issues were raised and missed opportunities to identify the scale and nature of the problems and put them right. So there were 4 very sensible key actions that were part of the recommendations to address how we get better at identifying poorly performing units. And the 4 key actions are monitoring safety performance, so making sure that we find signals amongst the noise. It relates to the board being falsely assured that the benchmarking was in line with national average. I'm sure a number of us can relate to that. Standards of clinical behaviour, that technical care isn't enough. And again, I think we can apply that to other areas of practice. So actually saying that somebody is very good at their job, they have the technical skills, isn't good enough. We expect a level of compassion and care and kindness, and not unprofessional and unkind behaviour. The third key action area was flawed team working. So the review team identified that the teams were pulling in different directions. There was bullying behaviour and conflict, which was evident to women and their families. And the final key action area was looking good while doing badly. So the Trust wanted to protect their reputation and reacted defensively. And the inquiry suggested that there is a pervasive culture in the NHS of putting reputation before honesty and openness. So NHS England wrote to trusts and the ICB in October asking that each board reviews the Kirkup findings, review their assurance mechanisms and considers the actions that they need to take. Esneft and West Suffolk have both completed this on respectively the 12th of January and the 31st of March, which is why there's been a bit of a delay in this paper, because we needed to be able to assure the board that that's happened in both our acute and community provision of maternity services. So just going through the 4 key action areas for the LMNSG. So we have our local maternity, neonatal and safety group, which has the delegated responsibility for commissioning, for agreeing our service development funding plans and oversight of quality. We have great representation from West Suffolk and ESNEFT and early years services in Suffolk and Essex. We have MVP and co-production partners, and we have NHSE. And our aim is to act as a unitary group. We've had some board development to facilitate and support us to be able to do that, facilitated by Tricordant. Within that group, we review information intelligence from data, service user and staff feedback and quality visits. We review the CNST submissions, CQC inspection findings, and we do quite regular clinical site visits. The governance is underneath the maternity board. We have a maternity safety forum that scrutinises local data, and an improvement collaborative, we didn't know it was one, but that's what it is, that then focuses on areas of risk. And most recent has been the work that we've done across the system on postpartum hemorrhages, which has seen postpartum hemorrhage rates for vaginal births improve and surpass the regional ambition for the last 2 months. So that's been amazing work across the system. And we attend both ESNEFT and West Suffolk maternity boards. Standards of clinical behaviour, that's been a key area of focus for the group working with ESNEFT and West Suffolk. We have seen some areas within our system that have raised areas of concern for the LMNSG, and from those concerns have come from Healthwatch, from MVP and Women and Birthing People. That's really improved dramatically over the last 18 months. We do, as I say, do regular visits, and our Director of Midwifery, Frances Bolger, visits the sites at least weekly, one of the sites, and the engagement and the feedback from Women and Birthing People on those sites has really improved. Firstly, it improved at West Suffolk, but significantly improved at ESNEFT as well, which is really great to see. We also oversee the leadership arrangements, working with the ESNEFT and West Suffolk boards. For pulling in different directions, we can demonstrate as an ICB how we listen and respond to the concerns raised. There have been concerns raised in both organisations over the years. We recently held a rapid quality review following concerns raised by ESNEFT staff to NHS England, and the review demonstrated that the ESNEFT leadership team had a good understanding of the issues. We will reconvene again to understand the progress made in the summer. From an organisational behaviour perspective, our role in the LMNSG is to understand how the trusts have oversight of maternity services, and our attendance at the maternity board supports this. West Suffolk maternity team present regularly at their board and have a clear relationship with the board, and at ESNEFT, Nick chairs the Maternity Improvement Board, which tracks delivery of their improvement plan. So I'm asking you to note the 4 key areas and to let me know if you're assured really with our progress on those 4 action areas. Thank you.
Lisa, thank you very much. So questions, colleagues, and specifically, is there sufficient assurance for you there on the 4 recommendations arising from the Kirkup report from East Kent? So questions? And don't see any, Lisa. Oh, sorry, Steve. Yeah, thank you.
I was wondering about the comments Andrew was making earlier about staff. Sorry, sorry about that, Lisa.
It's all right.
I was wondering about the comments that Andrew was making earlier about staff survey and staff confidence in bringing forward issues of equality, and their confidence that something would be done at the end of it. There were various too high numbers, I would say, of persons who were who didn't have sufficient confidence. Mm-hmm. I wonder if we know what the position is within the maternity services, where that sort of thing will be pretty critical indicator of the sort of cultural things that we've seen as problematic in other places that we'd wish to avoid.
Mm-hmm. So I guess we use our NHS staff survey to understand that. We use CQC assessments. So recently, Essex Colchester site was inspected and a number of staff interviewed, and there were no concerns relating to that raised by the CQC. However, the figure that Andrew reported will be spread, of course, across maternity services. It won't just be in one. So I think it is a continued piece of work to do. ESNEFT in particular are focusing on the culture in their maternity services, and they've just been part of a survey to understand what their safety culture. I can't remember the name of it. SCORE survey, I think it was. Yeah, to understand the safety culture within their maternity services. I think it's something that we need to carry on working on, really.
Sorry, Lisa, or maybe I should be asking Amanda about this. Would I be right in thinking that the staff survey can't drill down to the level that Steve was asking about?
In part, yeah, but I would also add that the freedom to speak up guardian policies that we all have in place may be another element that we want to exercise in terms of this wider.
Okay. Go on, Stu.
Well, I was just thinking, what's the data say? You know, kind of, how does it compare with the? If I remember those numbers that Andrew was quoted, was the averages for the system.
The safety culture
And I was kind
across
of,
the system,
if they come out for maternity, do they come out better or worse? And does that raise anything for us?
Right. Let me go to Nick first, and then I've got Fanwell, Craig, and Andrew. But we'll see which order we go in. But let me go with Nick first.
So first of all, yes, we can get down to that granularity. So we can look by site and by division and by clinical group. Do I have the figures to hand? No, I'm sorry. Can I get them? Yes. Will I make sure they're there for the minutes? Yes, if Joe chases me.
Excellent. Thank you.
I'll forget by the time I leave the room.
It will be in the minutes. Thank you. Thanks for that, Nick. So,
That was my comment.
That was your point. Okay, that's great. Let me go Fanwell first, and then I'll come to Andrew.
Thank you, Chair. So one of the things that we've picked up quite a lot, recently, but also in the time gone past, is that those who experience some of the worst outcomes are, the kind of people that are also less likely to engage with patient groups and surveys. So, in terms of what we're looking at, are there any specific initiatives that we're doing to look at, that we're having the voice of those people who are less represented?
So that's a massive area of our work, and actually we've been nationally recognised for that. So we do significant. Them been part of this work, supporting us. So we work with the African families in the UK. We commission them to do work for us with those groups. And Terry, our clinical lead midwife, probably spends more time with the grandmothers than she does with our team. We commission the youth education service that works with young mothers and supports them specifically. We commission Phoebe, and a whole range of people. We also have in the Ipswich and East area a Roma advocate who just works with the Roma community, supporting them through the antenatal process. And I know that our number of preterm births in that community since that advocate has been working with those families has dropped significantly. So I think we're really, within maternity services, ahead of the game on working with groups. There's always more, of course. There's always more communities we should be working with. But as part of our antenatal education model, which we're developing, there will be a one universal offer, and then we want to have community ambassadors working with those communities on specific bespoke antenatal education programs, which will be amazing. Thank you.
Okay, thank you. Andrew, and then Susanna. Andrew.
One of the things we try really hard to do in the quality committee, and I do elsewhere as well, is to look at data from a whole system level and avoiding wherever possible to looking at data from individual providers for two reasons. First of all, those providers have their own regulatory relationships with NHS England and are perfectly able to discuss their own performance with them, but also it risks pitting people against each other and setting up them and us type relationships, and we're really trying hard to do that as little as possible. I need to drill down into the staff survey to work out whether we can derive a system level maternity figure for staff survey, or whether we'll have to go to individual organisations. It doesn't stop us doing that, but I would just caution we have to then be careful how we use the information to make it as impartial and as supportive and developmental as possible.
Okay. So we'll ask you to adopt that thought process in the action. Thank you. Susanna?
So I just wanted to really endorse the work that Lisa's talking about. I mean, I think the way that the maternity programme have really risen to the challenge of, engaging with, particularly ethnic minority communities around the maternity programme has just been wonderful to see, and it's completely different. It builds on all of the conversations we had around what are we missing, but it does remind me about the fragility of that. So we've been fortunate, we've had some short-term funding through NHS Charities Together for the Community Ambition Programme. We've also had some short-term funding around community connectors, community ambassadors, and organisations like African Families in the UK, Phoebe, Bangladesh Women's Association. They're really key, and those relationships are fragile, and they're growing. We are in a difficult position around that, but we really must not forget how the learning that we had, and that if we're going to really address some of the inequalities, we need to make sure that we sustain that effort ongoing.
Thank you. So, colleagues, whilst noting that there is further work that we've discussed and which we look forward to hearing the output on, we're asked to say whether to agree or otherwise whether we have sufficient assurance that the recommendations 1 through 4 are being picked up in appropriate ways as described in the paper. Is everybody assured? Or should I say, is anybody not sufficiently assured? Assured, agreed? Good. Thank you very much, everybody. Thank you. Thanks, Lisa. In which case, let's move on to 16. Item 16, Amanda, ICB governance self-assessment, but then you've got a run of 4 papers, I think. So over to you.
Thank you very much, Chair. So this paper is for us to note as a board initially, and it's something that NHS England are starting to roll out across all ICBs. I think there's been a couple of pilot sites to date which we're taking learning from and hearing learning. But in essence, NHS England is inviting all ICBs to conduct a self-assessment. To an extent, the timing, and although I've put a timing in the paper, it pretty much is up to us to determine when we want to proceed with the self-assessment. But the primary aim and objective is for us to, like I say, do the self-assessment amongst the board, and it's looking at how we work as a board, what are the opportunities to further improve and continually assess going forward. So it's meant to be deemed a supportive framework of which we will be required to periodically comply with, but it's something that we're learning from the pilot sites. We need to agree the methodology, but the kind of findings that we're taking from talking to other colleagues is one of a self-assessment. And within section 3.1, I've identified some areas that we may want to include in terms of our self-assessment as a board going forward. I've also suggested that once we have received the work that Region are working on, and that's the templates to support, that we would potentially commence with the rolling out of the self-assessment in October, whereby we would then obviously collate, review the findings, look at what's being fed back through that self-assessment, with the view that we receive an interim report in January before a final report comes back to the board next March. So it very much is a supportive methodology, something that we can freely use and adapt as we move forward, but it's meant to support us and help us continually improve our effectiveness as a board.
Okay, thank you. And Nick, yeah.
Just to comment, I mean, it feels very early to assess how well we're working as a board, but perhaps an early assessment and then a review at a later stage will see those areas of improvement. In my experience, the theoretical governance of a board, the papers, the meetings, everything else, work really well, but it's only when something goes horribly wrong, and we've seen that in organisations up and down the land forever, that somebody then goes back and looks, oh, they were all a bit rubbish, weren't they, really?
Yeah,
So
yeah.
I'm not suggesting we wait until something goes terribly wrong, because it won't, because you've got the right people around the table. But I think it's just, how do we make it real? And in my experience of testing something in real time about a system or a situation that we may face, and then saying, have we got the governance there, rather than kind of theoretical approach? Because the systems, the processes, the committees, the accountabilities, the terms of reference, that'll all be there. But actually, how would it respond to testing, and how would we test it? A kind of desktop exercise or something. I don't know. It just feels
That's a good
bit,
point.
Otherwise, it's a bit kind of dry and theoretical.
So the real world testing.
Yeah. You put
yeah.
it a lot better than I did, Will. It's
No,
been
no,
a long
no,
day
no.
for all of us. So.
Yeah. And to be fair, we are on a journey of maturing, aren't we? Amanda, so just thinking about Nick's comments there, because the other thing is we're obviously under pressure. Well, we have to note the outline of the NHSE requirement, don't we? But we're under pressure to do something. On the timeline, item G, September 23, this will come back to the board, won't it? So might that be an appropriate time in that report back to the board to embrace the concept of a maturing board and how we're going to deal with it in the assessment?
I think that would be very good and something we can build into that draft timetable for sure.
You're happy with that? Yeah, thank you. And Lisa?
Amanda, I was just wondering if there's an opportunity to look at the CQC Chloe's and do it through that kind of lens, looking at the I statements and impact. I don't know. I don't know how it will measure against it, but certainly the well-led, the responsiveness, the finance use of resources, we could probably do that, and that would help us with readiness.
Great idea. Thank you, Lisa.
Sounds good. So I heard a number of yeses to that. Paul and then Tanya. Paul?
Yeah, thank you. I was going to make a similar point to Lisa in the sense that I'm wondering how this is going to work with system oversight framework assessment as an ICB conversation. So I think as much we can do to unify the approach between soft framework, CQC, and self-assessment, because invariably that will be perceived as a factor on how we are assessed as a system by our regional colleagues.
Okay, thank you. Tanya?
There's also something for me about quality of discussions and robustness of that conversation, and also thinking about how do we measure, capture, articulate the diversity of those conversations around the table. This feels very functional, where we can tick things. Actually, is there a deeper dive that could go alongside that?
Yeah. No, good point. And I know I can see Amanda's making notes of all these points, which you'll be able to embody in the next iteration. Susanna?
So I have 2 points. The first is a practical one, which is that we've just completed the NHS England, I think it's a quality development tool for looking at our relationships with the voluntary community and social enterprise sector. So I've literally Kirsten and I have just received the report, I think both this afternoon. That might be worth contributing into this discussion. But the other point I wanted to make is that for me, the quality of our integrated care system requires a kind of balance between kind of, what's described as new power and old power. So, we need to get the governance right, and we need to Tony puts it really, really well, we've got to get all the kind of checks in the box, but there's also that thing about how do we feel? How are the relationships? How are we working together? How are we collaborating? Those sorts of things. And I do wonder if coming up to our kind of first anniversary, we do a little bit of checking in about how are we feeling, not just around the table around this board, which is obviously the NHS ICB, but as a wider health and care system, a bigger partnership involving all partners in the system, and just checking in about the kind of quality of the relationships, because that's always been really, really important in SNE.
Okay, thank you for that. Noted. Any other thoughts, comments? I know, Amanda, I hope those comments have been helpful.
Really helpful, thank you.
We'll leave you, we're only asked to note here the NHSE requirement and the steps and timeline. I think we're happy with the timeline. We've agreed some sort of shaping and nuancing around the steps as discussed. Everybody content with that? Good, thank you very much. Amanda, I'm going to stick with you for item 17, please.
Great,
the
okay.
Fourth NEM appointment.
Thank you. So we covered this slightly earlier, but as an aid memoir, when we, in the early days of coming together, I think it may have been indeed our first board meeting back in July last year, we questioned capacity around our NEM, because at the time, and we still are of the view of 3 NEMs within our board, but we know that there was an issue around capacity raised then, linked to obviously the wider EDI agenda, and the two we've tried to move forward, but I think have got kind of tangled up, for want of a better phrase. So we're now detangling, and the issue of increasing capacity within our NEM has come to top of the agenda again. So whilst in September we agreed to increase our capacity from 3 to possibly 4, we took this decision to the last remuneration committee, and we were rightly challenged on the timing and the optics on the back of our running cost reduction that we need to be working towards from April 24. As a result of the remuneration committee, an options paper was then done and recirculated. And within that options appraisal, we did a couple of things. One, look at what other systems were doing to increase their NEM. And I think the conclusion of that was, since the 1st of July last year, the majority of systems have actually increased their NEM capacity from 3 to 4 to sometimes 5. And indeed, with regards to that, SNE was deemed an outlier. And the second challenge rightly was, is there another opportunity to perhaps look at not increasing to 4, but looking within our current resource and trying to make the 4th NEM work by not increasing, if that makes sense. And through the options appraisal, I think it was concluded that we did need to have an additional 4th NEM, particularly because we have a finance committee without a chair at the moment. And we also concluded that the finance committee chair needed to be of independence, which is why the paper that was recirculated to remuneration committee was actually recommending that we did proceed with the 4th NEM because of capacity from the current 3, but also that we needed to actually have a proper chair for our finance committee going forward. So this paper is coming to the board today to hopefully endorse the decision of remuneration committee to proceed with immediate effect to the recruitment of NEM number 4.
Okay, thank you.
Thank you.
Any questions for Amanda Fanwell?
Thank you, Chair, and thank you, Amanda. I think I just want to sort of reiterate the points that Amanda mentioned, but also, point out that particularly the discussions at REMCOM, which were around sort of looking at, are we an outlier in terms of what we're doing? And I think there's evidence in that paper that, the suggestion sort of sits right across there. But I think the point that Amanda mentioned again, which is around the optics of this, particularly in the time that we're in. And I think, having, and depending on what the board decides, with the option that is being suggested, I think there's still, something around assuring, our partners, assuring our colleagues that, at a time where there's quite a lot of anxieties around, where people sit, the perceptions around appointing a name could be, if not communicated properly, they could be seen in a way that is different to what we're intending. So I'm just, I think it's about how we communicate that, if this is to go out and approved.
So noted the importance of appropriate and correct communications. Yep. Any other points? Nick?
I suppose the question is, how does this fit with the previous paper around the self-assessment of governance of the board? Are the two related? Should we do one before the? I mean, it sounds like we've got to get on with this actually, but I think it should be reflected in that self-assessment of governance about whether or not we're hearing the independent voice as much, or is the danger of becoming an executive echo chamber?
Yeah, that's a very good point. And actually, the timing plays into your point about the timing as well, doesn't it? And the maturity. Thank you for that, Nick. And Howard?
Yeah, I think it also plays, Nick, into the financial plan paper. So it's crucial that we have a high-functioning finance committee. So I wholeheartedly support this, really. Thank you.
Okay, so with those supportive comments, are we happy to reaffirm because actually we did decide this whichever month it was in 2022, but we're being asked to reaffirm, given the passage of time and the events in the intervening period, we're asked to reaffirm that we still approve the recruitment of a fourth NEM. Approved? Done? Okay, good. Thank you, Amanda. In which case, back to you for 7 policies for approval, please.
Thank you very much, Chair. So we have 7 policies that have been through our Remuneration Committee and Audit Committee in March and April, as we can see within the paper. And basically, those policies have been scrutinised by the subject matter experts before going to the relevant committee. And they are here today for the board to endorse the decisions to implement. Thank you.
So simple as that. Any objection to approving those policies as presented, Ed?
No.
Not an objection.
No, not an objection. No. I guess this is intended to be the strategic board. And I know in our first years, we've had a lot of papers to this board, bringing policies, bringing strategies, 5-year plans. My question is, should we be bringing policies like this to the board, or should there be committees signing them off and we trust that they're in good order? It's just a risk if we continue to do this. We spend a lot of time signing off policies rather than talking about patient care.
Fair comment, Ed. And what we can do is take an action to revisit the terms of reference in terms of how the various committees approve and the like policies. So I'm very happy to take that as an action and look at.
Okay, and perhaps also reflecting in that self-assessment of, okay. Leave that with you, Amanda. Andrew?
So Amanda and I discussed this before, the point I'm going to make. So we agreed between us that in future, the Equality, Diversity and Inclusion work plan that we also need to bring back to this board at some stage for you to see will include a commitment to review of policies, really to make sure that the right checks and balances are put in those policies, to make sure that wider societal discriminations aren't inadvertently reinforced or perpetuated through the policies that we have as an organisation in our ambition to be inclusive and diverse organisations. So just to make it clear, that's a forward ambition.
Yeah. Okay. Noted. Thank you. Stuart?
And I suppose that's where, and I'm not sure where you are with regards to your own staff networks and about how you use some of them to try and challenge around the policies and the development. Something very strongly we have in Suffolk County Council feeding into those processes. But I think the other bit with Amanda was just thinking about your domestic abuse policy and stuff like that, about how you're measuring the impact of those policies as well. I suppose that fits into some of that evaluation piece.
Yep. Good. Thank you. So with those comments and future actions, today we're asked to approve. All 7 approved? Good. Thank you. Agreed. Thank you very much. In which case, item 19, declarations of interest to receive and, oh, sorry.
I'm sorry to come back on
No,
policy,
do come back,
on
Nick.
policies,
Go on,
but
go on.
I've always found it extraordinary that within the NHS we've got organisations with different policies. I mean, if you walk into, they've got the same sickness policy in every Marks and Spencer's and every police station and everything else. So I suppose it's just a question: at what point do we have an ICB policy to save all of our committees, and we've got staff networks and we've got everything else? At what point do we just say, look, we'll just adopt? I mean, I'm sure there may have been a little bit of plagiarism in some of these policies, dare I say. I want to be honest about that. Say there's an ICB policy around managing sickness or managing, so it just saves it, and then there's, then you can passport staff much easier and everything else. Yeah. Just maybe something the HR directors could
absolutely.
look at. Group, sorry.
Yeah.
And if only it was that easy, Nick. And
I know, but if nobody's going to stand up and say we're going to do it,
Indeed.
then what are the legal? What stops us doing that legally and challenge it? Because if we want the NHS and healthcare to be and social care, third sector to be working differently, if we're not going to challenge it, nobody else will.
I completely agree with Nick, and I think I'd like a little plea to both yourself and Craig to maybe help me get to where we need to be, because
I tend not to be outspoken, so I'll leave it to Craig.
Because we did have quite a heated conversation at a recent People Committee, I think on the back of Nick, you raising the challenge at a previous board, and it's unfinished business. It is ongoing, but if you could help us get to where we need to be, perfect. Thank you.
So I saw Craig nodding as well there, so we'll take that as agreed and collegiate action.
Wonderful. Thank you very much, both.
Thank you very much. Thank you. So, ready to move on then to the next item? Okay, declarations of interest, etc. Amanda, back to you.
Thank you. So this is a report that we present to the board twice a year. So this combines our declaration of interest and our register for gifts and hospitality. So it's really here for us to note, and I guess it's to consider, is there any additional action that we as a board may want to take in terms of making sure the declarations of interest is as robust as it can be before we update and publish on our website.
Okay.
Thank you.
Thanks, Amanda. Any comments, any thoughts around future or actions required as we are? Otherwise, are you happy to publish? I think nobody's saying no, Amanda, so we're going to take that as
Thank
approved.
you very much.
Ready to publish? Agreed. Marvellous. Item 20, committee minutes and highlights report. Now, Amanda, your name's against this, although obviously there's a lot of different minutes underneath it. Shall I leave it to you to kick off?
Yeah, that'd be great. Thank you, Chair. So I think in previous boards, we've taken each committee and invited the Chair to bring to our attention anything that we need to be made aware of from the minutes that are attached. So if perhaps we could start with Steve in terms of audit committee, please.
Nothing much to add, but that's fully been taken care of on the agenda. Most of the meetings taken up with the 3 sets of legacy accounts, and you've already had the policy that we recommended.
Great. Thank you, Steve.
And any questions for Steve and or Howard, or is everybody happy to receive a note? Received and noted. Back to you, Amanda.
Thank you very much. So Tanya, Remcom and HR committee?
Yeah, nothing extra really. Lots of discussions about culture, morale across the system, kind of how it feels really for people. I think we're trying to get a bit deeper into that. Lots around industrial action, as you would imagine, and the system response to that. And at Remcom, we had a really robust discussion about the NEM role, which didn't fly through. So that feels like it was the right thing to do. So no, nothing extra than those things. Thank you.
Thank you. And any questions for Tanya? No, received and noted. Back to you, Amanda.
Thank you. And in terms of finance committee, am I looking to Howard here?
We need a finance committee chair, don't we?
Yes.
Edward Creasy would normally be doing this.
These
There's-
are apologies from Edward for today.
Apologies from Edward. There's nothing else to report over and above what's already been reported to the board. Thank you.
Okay, and any questions for Howard? Otherwise, received and noted, and back to you again, Amanda.
Thank you. And moving to People Committee, Tanya.
Oh, sorry, I wrapped it all up together. No, nothing else. Thank you.
No problem. Thank you.
And any questions on People Committee? No, back to you again, Amanda.
Thank you. And then in terms of the People and Communities Committee, am I looking to you, Lisa?
There's nothing to raise.
Okay.
Nothing to raise. Thank you.
Nothing to raise. Any questions? And none, and therefore finally back to you for the estates one, Amanda.
Thank you. I don't think there's anything to highlight apart from we will be having our system infrastructure estate report coming back to a future board meeting. But that's probably the only thing that I'd want to raise, Chair. Thank you.
Okay, thank you. In which case, item 21, the attendance log is there for receiving and noting. If there are no questions, we'll simply receive and note. Done. In which case, any other business? I've got 2 items, but non-notified. Let me just look around the table, see if there is any other business. No other. Oh, Tanya, sorry.
Sorry, Will, I should have picked it up earlier. Just in terms of NEM recruitment, kind of offline discussion, can we just make sure that we're doing that in the most effective way to get some really good diversity? I'm slightly nervous that we might just be fishing in the usual pond. We talked earlier about interims. I think we just need to make sure that we've got a good field, not just going down one track.
No, that's absolutely right. And I can see Amanda nodding. And in actual fact, that was the initial debate, which I think I remember being in July 22 and then September 22. The diversity was part of the need to improve the diversity was part of the initial drive. So should we take that as not forgotten, shall we say? Part of the journey. Yeah. Okay. Any other business? Otherwise, if there is none, I'd just like to thank again Steve Clark and Patrick Warren Higgs, noting that this is that's the end of their last meeting. Patrick isn't here, obviously, giving apologies today, but Steve, thank you very, very much. Well, to both of them, but Steve, thank you very much for everything you've done. We look forward to seeing you again and hope that the going on to greater and better things is really successful for you. So thanks very much. And perhaps we could say thanks to Steve in the normal way. So thank you. Date of the next meeting is the next scheduled public meeting, 25th of July in Bury. But I think the likelihood is we will have a virtual public meeting on the 20th of June, albeit that has not yet been confirmed, but that is likely, I think is fair. Okay, so now questions from the public. So first of all, anything down the streaming, Simon?
Yes, we've got one question here, which is from Barbara Robinson. The question is, as a priority condition with national identified significant unmet needs, in brackets ME and CFS, ICBs have been tasked by NICE to develop a delivery plan, which SNE has done. With priority listing within the SNE's 5-year forward plan, will co-producers for the ME service be invited to be part of the above subcommittee? And there's 2 questions to this. What are the terms of reference for this subcommittee, please? And the second question, who has been appointed to date and when are the meetings scheduled?
Right. Now, how do you want to deal with that one, Ed?
Well, it's a very specific question, isn't it? So if we get a written answer to Barbara with the terms of reference, etc., and then we'll see if that satisfies the question.
Okay, thank you. Anything else, Simon, or is that it? No? Okay, so colleagues in the audience, I've got 2. Let me, who wants to go first? Jump up to the table. Yeah, all yours.
Good afternoon, Chairman and Committee. It's, I think, a couple of months since I sat before you last, and the result of that meeting, I think, was we ended up with a meeting between the 3 PPGs in Felixstowe and Maddie. She came along and took questions, I think, from the PPCs across 3 surgeries. And the concern that those of us living on the peninsula have is that we are going to have a population increase of around 10,000 people over the next local plan period. Now, I missed your last meeting because I was attending a family funeral in Devon, but you may have been made aware from Mandy that she had that meeting with the 3 PPGs, and I think the solution was that we would go out to consultation, or rather you would go out to consultation. I think I would be right in saying that those of us that were at the meeting considered that to, in some respects, to be kicking the can down the road. What we were really worried about is, whilst we are consulting on things for the future that could improve primary care delivery within our area, what we really want to know is what we're going to do in the here and now, whereby we see houses being delivered on a number of estates, those houses being occupied. We're aware that all 3 surgeries are currently oversubscribed since the closure of Walton. And since that particular meeting, I've been to a site that is virtually built out called Poppy Fields. And when I looked on their board of what wonderful things they were going to be doing with the sale money that they are contributing to the local council, I noted that 60% of that money has already been allocated, and it's been allocated for pre-primary school and primary school provision. That's not leaving very much over for the provision of secondary education, for health provision, for highways, sports, playing fields, and all the other things that the community infrastructure levy should be delivering. So it is very concerning. How did East Suffolk District Council, or as it was then Suffolk Coastal District Council, set a levy which in the Felixstowe Peninsula is the least of all of the sub-districts within the district? Is that community infrastructure levy going to be sufficient to meet the primary care needs within our community? Did the CCGs have a separate 106 agreement on each of these sites that are being built out? And one of them, Trelawney Lawns, that's actually going to have 2,000 plus buildings put on it. If we've already spent nearly 60% on just a small part of community infrastructure, I'm really worried that to a degree we've already missed the boat. So I would like some reassurance from this board that you haven't missed the boat, that perhaps there is a 106 agreement on each of those developments that are coming at us. And if we have, what are we able to do to actually ensure that the folk that already live there will continue to receive the appropriate health care that they should? Thank you very much.
Thank you very, very much. Maddie, do you want to have a go at answering that? Although some of the detail may have to be in a follow-up, I would imagine, but over to you.
Yes, thank you. So I believe when we came to meet with the PPGs, we confirmed that we would be undertaking a detailed piece of work to understand the full demand as it is today, as you rightly point out, and what that was forecast into the future. And that piece of work is ongoing, and we confirmed that we would report back an interim in June. So we will do that. We also, as you know, had conversations about engagement with the community and opening up to views about the needs and the aspirations of the community. There has been, that has begun. We were very careful about that during the pre-election period, but that work has also begun through the SNE, Let's Talk SNE website. There is ongoing dialogue with our estates leads and East Suffolk Council. So this work is ongoing. There's also detailed engagement between the League of Friends and our colleagues at ESNEFT. So that's very live. I know I've seen further emails about that today. So whilst I don't think I can answer all of your questions today, Michael, I think I can give you assurance that the work is ongoing and that we will be able to return with those findings and consideration of the next steps.
So in June, report
Yes.
back in June.
Yes.
Okay, lovely.
I really didn't hear assuming it's so, because if for the Felixstowe Peninsula is the least discharged across the whole of East Suffolk District Council, if there isn't a 106, and if the sill that has already been agreed and taken from the developer will not meet our needs, what then can this board do?
Maddie, would it be
Yeah.
would it be possible for the paper that's going to come back to deal with that, to check the facts and deal with that issue?
Yes, I
appropriately?
mean, there are others far better qualified than I to talk in the detail about Section 106 and still monies. Yeah. However, obviously they are one source of funding, and there are others that may be available. But it is true to say across the whole of our area that we're in an exceptionally challenged position in terms of capital sources. So that does mean that we do have to prioritise, and it does mean that the contributions of our local authority partners in the way that you've described are very, very important. So, there's a level of detail I think we need to return to.
So issue not missed and further information to come. Thank you, Michael. Yes, so were you... yeah. Oh, right. Okay. Over to you. Yeah. Yeah, press the button. Yeah. Yeah, that's it.
Chairman and board members, thank you, Tom and Michael Taylor. I've got a couple of things. First of all, a statement and a question. Andrew, you talked about digital inclusion, and obviously it's part of the strategy. I just wanted to I guess, make a statement which, as a nation, we need to include the uptake of digital, but recognise there's a portion of people that won't adopt it. So we need to be inclusive and support all of those people. You also explained, and it's great to hear, the digital link between social care and the NHS. I was interested in understanding a little bit more about the link between primary and secondary care. At the moment, in the press, we hear a lot about outpatient waiting lists. And in some instances, they have come from primary care. But is digital on the programme in terms of getting digital applied in communities and primary care in order to drive down the outpatient waiting lists in acute? Because in some instances, it's reducing backlogs by 10%. In some cases, it can be 60% because it's removed. Thank you.
Was there anything? Was that it?
Yes,
Michael. That was it. Okay. Andrew, I don't know whether you want to pick that up now or how much of it needs to be fed back later, but I wonder if Nick and Craig might have some thoughts on that as well. So how do you want to handle it?
I was going to suggest I gather some information and respond in writing to that question. There's again, a level of detail of what's happening in some parts of primary care that I'd rather give you accurate facts than general ones.
Go on, Nick.
Thank you for the question. I was just going to ask, you mentioned there about outpatient waiting times being, waiting lists being slashed, but I wasn't quite clear what the IT interaction between primary and secondary care had with achieving that. So I just wondered if you could clarify.
The clarification is really a lot of referrals from primary care are being pushed through to the kids who are trying very hard to get rid of them. But a lot of the triaging hasn't taken place in the community or in primary care. So a lot of those people, the digital is one of the options you can do. It's a means of actually driving down those people who actually end up in the acute sector. So that's why I was mentioning digital has to be
Go on, Craig.
So a couple of points. One on digital inclusion. So we've been consistent all the way through our digital journey, and I think that's true across the system, that it's digital first but not digital only. So there has to be a non-digital option so that we don't exclude sections of the community. We already have links between primary care and the acute hospital and community services, so that information can be seen in whichever area of the health system you are, which means that people have all of the information available to them before making those referral decisions. So what you don't get is a referral in order to gain information that is already available. Sometimes, particularly when requesting tests, if you haven't got the test results available to you, you can often repeat a referral, and we hope to eliminate some of that. There's a lot more work to do on stratifying the community around in terms of health information in order to do some of the work that I think you were suggesting, which is being much more proactive with the community based on good data. But that's definitely an intention, but we're a long way from being where I think we should be.
Okay, thank you. And further information to follow in a written answer. So thank you for that, Andrew. Colleagues, I think we are done, if I'm not mistaken. It is 11 minutes to 5. Well done, everybody. Meeting closed. And for board members, we have a confidential session to follow. Can we start promptly at, say, 5 to 5? Would that be a good idea? So we've got 5 or 6 minutes, change the atmosphere, change the room, get a cup of coffee if you need one, but back here in 5 minutes. Okay, thanks, everybody.